So it's certainly an honor and a privilege to be here today. And as I said earlier, I've done this before. It's a huge undertaking, and I certainly would like to thank the organizers for all the work that they've done, and I know this is going to be a great meeting. And I want to thank also the folks that come here and spend a lot of time and effort in doing research in this and trying to share with you some of the insight, some of the new things that are going on. Now, as Dr. Vez said, there's no question kids are different than adults. But there's similarities too, and I think, again, for those of you here that have children that have had this will be very pertinent. For those of you who don't have kids that are as adults have had Chiari, this will still be pertinent. So I'm going to share with you some of the new things, some of the areas, the new developments, the things that we all look at, and I'll share with you some of the basic issues with kids and how we deal with that. And a lot of this is data from our own institution. And obviously, at the end, we'll be able to have time to talk. We have been very grateful for the support we've received from ASAP. We've had a number of research projects that have been involved. You'll hear more about this tomorrow, and I'm certainly not going to do a rain on the parade of a number of folks to be talking about some of the work we've done. I think the thing, I come away from these meetings every year, hopefully a little wiser, a little smarter. Certainly learn a lot, and always come out of here feeling like, wow, that was fantastic. I learned so much. But I also come out with this feeling like, wow, there's so much we don't know. And every year I think I know a little bit more about Chiari than I recognize there's a whole nother reverse triangle or pyramid of how much we don't know. And it is part of the cost of being involved with this. So again, I think most of you in this room at this point, if you don't already know, should know that Chiari malformation represents a herniation of part of the brain, the cerebellum, the cerebellar tonsils, and people still sometimes get confused between the tonsils in your throat and the tonsils in the back of the brain, below the foramen magnum. And you saw Dr. Nimchinsky's talk earlier, which is great, and gave you a little bit more insight into that. There are all kinds of variations in a theme here. And we have folks in this room that have done a lot to define some of these variations, the Chiari 0, Chiari 1.5s, and so forth. And I'm sure to you, as it is to us, what's the deal? Don't these guys know what they're looking at? Can't they figure out what's going on with all these different numbers? And do we have a Chiari 1.765 and all that sort of thing? And the hard part of this may represent a continuum. Or maybe it's a different disease depending upon the patient and the age. And obviously kids are at the early part of that spectrum versus some of the folks that are older. So it's hard to know what it really means. But they do present differently. There are different clinical parameters involved with this. And I think as a clinician, and probably as the patient too, you need to understand some of the nuances of the things that are involved with this. The other part that's come up, and you'll hear lots more over the next 2.5 days, what's the clinical significance of the symptoms? And I know Dr. Vez is talking about that, I think, later today and so forth. I think it's important, again, to look at the forest and not the trees. And I've said this before in front of this audience or other audiences at this meeting and elsewhere. You've got to look at the big picture. You can always find symptoms that apply to you and have nothing to do with what an x-ray finding is and so forth. And we're taught early on, treat the patient, not the x-ray. No disrespect to the radiologist, but it's part of a bigger continuum. And you have to keep in mind that not all headaches are related to the Chiari, just because there's a Chiari on an MRI scan and so forth. So when it comes to kids, the symptoms are dependent upon the age of the patient. A 2-year-old will have a different story, different presentation than a 10-year-old. And they're very variable. And I say every patient and every family, every patient or kid is their own textbook. And I think, and I continue to see variations on a theme that surprised me after doing this for 30 years, where I say, well, I've never seen that before, but it's real and it's significant and so forth. Now, headache, occipital headaches, cervical pain type of headaches, that would certainly be at the top of your list for a Chiari patient. But again, not all headaches will be related to that x-ray finding. Certainly a headache that's increased with a Valsalva maneuver, an exertional type of effort and whatnot, makes you pay attention. Not always the case, but it certainly makes you pay attention to this. Pain in the neck, stiffness, weakness or paresthesias, pins and needles in the arms and legs. Again, maybe something else, but certainly in the setting of a Chiari, add credence to that. Balance issues, gait issues, walking and so forth, trouble with eye-hand coordination, texting. Kids are big into texting and so forth. All these things are important. Swallowing problems, articulation, hypophonation, where you'll sometimes see folks that have had significant Chiaris and brain compression where it's hard for them to get enough air out to be able to hear them speak. Double vision, and certainly apnea, nighttime dry coughing. And then there's the old fatigue and decreased stamina. Well, you can feel lousy and have decreased stamina for many reasons, but it certainly seems to be a very common parameter in the setting of Chiari's, both in kids and adults. And it's often interesting, you'll take care of a patient and you'll solve all of their problems except for the fatigue, and then 9 months later, a year later, the families will tell you, the kids will tell you, I'm starting to feel myself again. So, that's a whole other thing. I kind of look at fatigue as the red light on your dashboard. Of course, nowadays it tells you what the problem is, but the bottom line, it's something isn't right, but that can be a very difficult thing to try to determine and figure out what to do. And then, of course, you got fill in the blank. There's all kinds of wild and crazy stuff out there that is very often part of the Chiari that isn't necessarily clear-cut. Well, how do these patients present? Certainly a good clue that there's a problem is it's hard for them to move the neck. In particular, it's very hard for them to look up. And you can think anatomically of those tonsils being pushed down on the brainstem or in a very tight space. Kids, I've had a number of patients show up at 9, 10 years of age with a lazy eye out of the blue. That doesn't happen that way. It happens in younger patients. That should certainly make one worry about a cranial nerve issue. Balance changes, gait issues, falling, stumbling, not uncommon. And again, you need to look for this. Very common for the peds folks in this room, the pediatric neurosurgeon, is the scoliosis. The kids come in with a scoliosis. They get the MRI. The MRI shows a large syrinx, and the syrinx is secondary to the Chiari. Probably not a new story for a number of you that have read up on this or have been involved with this. Wasting of the muscles in the hand, atrophy of the intrinsic muscles. I've had a number of patients. I always look at the hands, and it's very frightening. I had a mother who was a physician whose daughter had scoliosis in a syrinx, and when I pointed out the intrinsic wasting of the hands, it was very hard for her to accept that as a physician. She didn't see that in a kid. These are subtle things, but you need to look for them. And spasticity and increased tone and walking in your toes and things like that. As you would imagine, there's lots of stuff. A lot of kids out there with headaches, dizziness, fatigue, malaise, a lot of adults too. We're talking about kids. And unfortunately, Chiari is out there in roughly 1% of the population. I'll expand on this in a few seconds. And so what is the significance of Ehlers-Danlos syndrome? I'll talk more about that as well. And what's the significance of pseudotumor, what we call intracranial idiopathic hypertension? Is that the 800-pound gorilla in the room? And these are things that really come up much more so early, at least in the pediatric setting. Now, there are a lot of other associated conditions, and I see there's a talk later on this, so you'll certainly get more about this. EDS, Ehlers-Danlos syndrome, and I suspect a lot of you in this room, who knows what that is? Who's actually seen, read, been involved with it? So it's not a stranger to the Chiari community, and I now look for it. You don't know if it exists if you don't look for it. And I think as we get older and wiser and experienced, you start looking for things, and you're always surprised at how prevalent things are when you just weren't looking for it before. It doesn't mean that it's increased or it's epidemic. You just weren't looking for it. And I probably see 20 to 25% of my patients have some manifestation of this and a Chiari malformation. And then the trick is what's real and what's contributing and what and so forth. A lot of midline issues, metopic ridging in the forehead, hydrocephalus, tethered cord, pituitary dysfunction or hypofunction of the pituitary gland, basal invagination, encephaloceles, calvaral defects, cleft palates, and then you got the outliers, the NF, the neurofibromatosis, and autism. And it's hard to know, are we just doing more MRIs because these kids are syndromic and they have need for these pictures? We obviously are. Is that driving the fact that it's an issue? Or is there some genetic or overall issue where they actually are connected? And that's very hard to know without real science. And you'll see, I think, a talk on Friday from the folks from Duke who have been doing a lot of good work in the genetics of this. Once we begin to get an understanding, what is the underpinning of this disease process, we'll know, are they related on the same gene, same chromosome, so to speak, or is it something completely different? And unfortunately, at this point, we're starting to get more and more real data, but it's still very anecdotal out there. So we were curious about this last year, and we looked at our patients at that point and found 7% of our kids that had had surgery or had a Chiari documented by an MRI had a defined family member, X-ray proven or surgically proven, but legitimate Chiari malformation. And that may very well be an underrepresentation, but certainly it's a real number. And when we looked at these patients that had the familial issues, the incidental Chiari manifestation was lower in that group. The surgeries seemed to be about the same for the family folks as it was for the non-family folks, and they seemed to have a little bit more headache. So there were some subtle differences. Hard to say if it's significantly different, but nonetheless, it's a very real issue. We didn't see any predilection towards autosomal dominant or recessive transmission. And now I have 4 families that have more than 3 siblings. I have one family with 5 kids, and they're all different. And the patient and the mother and so forth is different as well. And not surprising, these folks have other conditions, so it's probably some type of genetic connection here and so forth. And the other thing that's fascinating is you'll have these families and patients, and it's a real challenge when you got 4 kids in your office, and you're trying to see them in 10 minutes for all 4 families. It doesn't work, obviously, but they're always different. The pictures are different. The presentations are different. You'll have 2 kids with the worst-looking picture, MRI pictures you've seen, and one kid is asymptomatic, the other kid's having spasticity. So it's very, very variable, and it's part of the equation that you have to think about when you see these kids and their families. The question comes up all the time. Are kids different from adults with respect to Chiari malformation? We know they're different from adults, but are they much different when the way they present and so forth? And unfortunately, there's not a lot in the literature, and that's partly because there are not a lot of folks that deal with kids and adults and have followed them for years, would have that kind of database. So that's going to be a tough thing to get, where you can have at least a continuum or continuity of care to be able to make a meaningful difference. When we looked at our own experience, and we looked at the age of patients, as you can see here, see if we can do this without, well, you can see on the slide, as the kids get older, and that's the bars to the right of these different areas, the likelihood of apnea, symptoms in the extremities, neck pain, scoliosis, and syrinx do appear to increase. And that's not a huge surprise. I always wonder what was happening to the 30, 40, 50, 60-year-old patients that present with Chiari. What was going on when they were 10 and 5 and 20, excuse me, and so forth. So there's no question there's some type of progression or involvement of this condition. So I think there is a difference, but it may be a part of that continuum we were talking about earlier. So what about the etiology? What causes this? And a lot of time and effort spent into this. A number of people in this room that have done a lot of work in this area and are certainly well-recognized international experts. We still don't have the whole picture in this, and it may be a while before we do. And that's because these patients present differently depending upon what the issues are. It may be a different condition in a child than it is in a 40-year-old. And we certainly know that if there's pain, that's because of some type of direct pressure or indirect pressure on the head. A neurological finding will probably be related to some type of brainstem and or cranial nerve involvement, which doesn't always exist or doesn't always manifest itself with the patients. And of course, you've got Syringomyelia, and that's a whole other story where it's probably more of a plumbing problem where there's an obstruction to CSF flow. I try to keep things simple. I'm a big believer in the KISS philosophy, keep it simple, stupid, and I refer to myself. I think this applies to neurosurgery as it does to a lot of other things. And I kind of look at this as, is it a volumetric issue? There's just not enough space. Things are being pushed out of a small space. Or is it a pressure issue and the spinal fluid itself can't get out? And we've been trying to work on this. Then we've got anomalies that are there from the beginning of time, craniocervical anomalies, instabilities, connective tissue issues and so forth, and how does that play into this, and that's where EDS is part of this. And then again, the thing that really bothers me the most, and Dr. Rakate may talk about this later, because Hal's done a lot of work on this, is what's the deal with these occult hydrocephalus patients or pseudotumor patients that have pressure. There's no question if you have pressure in your head, your tonsils get pushed down. And we have kids that are treated for pseudotumor, the symptoms go away, they'll look better, and the tonsils are back up in the head. So there's no question that's a big part of this, and it may be as high as 20% of the pediatric patients have some manifestation of pressure. The downside is we don't have a non-invasive way of telling what your pressure in the head is, although we're working on that and getting relatively close to being able to strap this thing in your head and telling you 10 minutes later what your pressure is with some degree of certainty. But all of these things are problems. Does the extent of the posterior fossa decompression matter? Does it correlate with how well the patients do? And you'll see and hear from Dr. Sue tomorrow, one of our residents in neurosurgery who's done some beautiful work on this. The answer is it may very well, and I don't want to rain on his parade or spoil the show, but there is definitely something going on there. Mark Quigley's in the room with us right now. Mark's been looking at, and you've heard some great work earlier about Dr. Nimchinsky. What about the flow, and is this the hidden picture? You look at an MRI picture, it's a static picture. It's a Polaroid, it's great, but you need a movie to get real-time, dynamic type of information. And ultimately, the real question is the flow may be slow, it may be fast, Bernoulli effect notwithstanding. What does that mean clinically? And where do you put that into connection? But it's at least a real-time piece of information, and Mark's done some beautiful work, and again, I'm not going to ruin his parade. He'll spend some time with you tomorrow telling you what we've done and what that's told us. So what about the natural history? We're in a good spot taking care of kids in a busy hospital to see billions of patients with incidentally found Chiaris. It may not be billions, but it's an awful lot. And so if you look at the natural history, we still don't understand the natural history of Chiaris that well. We do know that if you look at a lot of radiographic studies, autopsy studies as well, it's out there. And it's roughly 1%, 0.8 to 1% of the population has a Chiari and does not even know they have it. Been a lot of folks looking at this over the years. Back in 2000, our senior pediatric society put a survey out and said to folks, if you've got a patient with an asymptomatic, incidentally found Chiari, do you get worried? Do you do anything about it? And the answer was 2/3 of the time from the participants was, no, what are you worried about? Don't worry, it's not an issue. Don't get excited. Don't even follow it. We know that isn't true. And if you see below this the list of studies in the recent time frame that have looked at incidentally found Chiaris. And certainly Dr. DeRocca from Italy looked at this recently and found that 16 of their patients followed for roughly 6 years. Not half of those, 3 of those went on to have issues, but probably issues with hydrocephalus. Cormac Mayer was supposed to be here today, and I would love to have heard what he had to say, but the folks in Michigan, at Michigan, have looked at this, and they looked at 147 patients seen to have a Chiari malformation on their MRIs, and asymptomatic, was a retrospective study. We'll talk a little bit what that means. But they found that 9 of those patients went on to have symptoms, and they had a 4-year follow-up, so a decent time frame, and that 14 of these patients, or 10% of them, required surgery. So it's out there, and we're not suggesting that every child or adult that has an asymptomatic incidental Chiari should have something done, but I would also say it's not something that you should just blow off and call me if you're having a problem. And we'll talk more about that in a second. So we look at our experience in Washington, D.C., the Children's National Medical Center, and this is over 17 years. We've had 746 patients come in with a diagnosis of Chiari, roughly the same males versus females, and the average age was 8.5. And if you look at patients that have been back for more than 6 months, a lot of folks show up, they go elsewhere, they don't come back, probably go and see Benny in Wisconsin, who knows where they go. But if we look at the patients that return after 6 months, we've got roughly 60%. We've still got 444 patients, so that's a legitimate series. 2/3 of our patients are incidental. We do follow these kids. I'll share more with you in a second. A 5th of them have Syringomyelia, so it's a common issue. And about 1/4 of them go on to require surgery, at least in this cohort of patients that we looked at. And you can see here the average age is 9.5, about 8 months before they go to surgery. And 2/3 of them had progressive symptoms. 46% of them actually had a syrinx at the outset, but there is a small subset of patients that develop a syrinx, so you may say, well, can that happen? It definitely happens. And you can see 18% of them scoliosis and so forth. When we look at the surgery, 2/3 of the folks had the big operation, bone, dura, sometimes a 4th ventricular stent, but the big deal. And then about 1/3 in our series had only the bone, and we can talk more about that later on with a 4-day length of stay. 80% got better. 10% came back for another operation, and roughly 7% stayed the same. And if you look at complications, if you take all kinds of things that you don't want to have happen that keep you in the hospital longer, it's almost 1/4 of our patients when we look at all of the patients as a whole. If you exclude all the CSF collections, leaks, whatever that may be, and look at neurological, other things like infection, it's only 6%. So let's shift gears and talk about incidental Chiaris. And we've been doing a lot with this, and I think we're ready to put something out there. We've got enough time and so forth. We take 5 millimeters as the lower limit of tonsillar herniation, and these are kids that come in unexpectedly and are seen to have a Chiari malformation. They have a history of occipital headaches or any of these things that you see out there that would suggest that they may very well have a Chiari, but it hasn't been appreciated. We exclude them. That's just not fair to say because somebody didn't pick up these symptoms. These are kids that come in car accidents, ADHD workups, seizure workups. There's a million reasons in a big children's hospital to have an MRI scan. And if you can see in this slide, it's very interesting. In the last few years, now that we're looking for it, the numbers have exploded, and we get roughly 50 plus kids a year that are truly incidentally found. And obviously in the old days, if you go back on that slide, the 90s and the early 2000 time frame, we really weren't cognizant that this was an issue. So we've got roughly 500 patients over that whole time frame. Again, their follow-up, if you take out the kids that were there just for under 6 months, we've got about a 4-year follow-up, a little short of that, a 3.5-year follow-up. And not surprisingly, a number of these patients have syringomyelia. It's classic. The kid comes in, they have a car accident, the CAT scan looks suspicious for Chiari, they get the MRI, the kid looks fine, there is a Chiari, but no one's looked at the rest of the spinal cord. You bring the kid back a couple months later, and lo and behold, they have a pretty impressive syrinx at T8, T9, whatever it may be. So you have to look at the whole spinal cord. But in this group of all patients, retrospective, prospective, roughly 12% of these patients ended up getting surgery when they first came in, incidentally found, asymptomatic, and so forth. And again, looking at this, progressive symptoms 60% of the time, 8% developed a new syrinx, and so forth. 2/3 the big operation, 1/3 just the bone, and more importantly, 84% got better. 5% went on to have another operation. Obviously, they didn't get better, and about 10% had no change. Now, here's the interesting thing, and I think for the folks that did the science in here, retrospective studies have a lot of problems in them. There's a lot of inherent biases. And so we really wanted to start looking at this prospectively, bring the patients in, follow them long-term to see how they did. And so when we actually started looking prospectively, the numbers obviously are less because it's not the whole. And we had 320 patients. And again, 10% of the patients had a syrinx. And we needed patients that were prospectively followed with at least 6 months or more follow-up. And we end up with roughly 2 years follow-up. But a cleaner, perhaps more pure population. And now you've got a 7.2% going on to require an operation at some point versus 12%. So there is a difference. And when we compare these two, it's 0.1, so it's not a huge statistically significant difference, but I think part of that is there's a trend in that direction. As we have more numbers, it'll become more and more obvious. But if we're going to start to try to make any meaningful assessment of who's going to go on to have a problem, and what's the likelihood when you say to a mother who has a 9-year-old in your office, what's the chance that kid's going to need surgery, you need to have clean and meaningful numbers. What are the factors that we've seen so far that would imply if this child has an incidental Chiari, they're going to go on and require surgery? Well, positive family history is worrisome, and you can see there that it's definitely statistically significant. If they have a Chiari 1.5 where you have medullary kinking, and you may or may not know what that is, but I'm sure some of you have seen this. And if we see tonsils below 10 millimeters, now I agree with Dr. Vez, the degree of tonsillar herniation isn't the issue. The issue is how tight it is, how is the CSF flow, but it seems that the folks that have lower tonsillar herniation are at a higher risk. The gender, the age, tonsils somewhere between 5 doesn't seem to make any difference at all whether going on to require an operation. Now, when you look at the patients and you say, okay, what's the likelihood you're going to have surgery, and at what time frame? How long do we torture the child and the family getting follow-up MRIs and coming to see me and waiting all day long for me to show up? When we look at all patients that have incidental Chiaris with a follow-up of roughly 41 months, you can see that 92% of these patients will have a problem by 2.5 years from the initial diagnosis. What's fascinating to me is we do have some of those outliers. You see the one at 54 months. Further out to the right of that picture, you see 7, 8 months. I actually have a second kid that's now 7 years later from incidentally found. And I always worry about what happens to these kids when they're 30, 40, 50, what's going on? And so I think when we have 20, 30-year follow-up, God forbid, it'll certainly shed some light on where does this all go and what happens. If we look at just the prospective kids, shorter time frame, because we've only been doing that for the past 5 years, but you can see, again, most of these patients, it's amazing to me. You'll see a kid that's perfectly fine, asymptomatic. You're trying to explain this to the parent, looking like you're out of your mind. And now, what do we need to do with this? And then there you are 6 months later, the kid's having neck pain, or the kid's having some issues, and God forbid, they actually have a symptomatic, problematic Chiari that requires surgery. But it usually shows up within a couple of years. Look at the complications. 15% for all patients. We look at 195 surgical patients over the last 15, 16 years. It's a little higher for the incidental patients, but statistically not a huge difference. Most of the complications we see, and this is 5 different surgeons over 16.5 years, are related to CSF. And back to the question, is there a CSF problem? Do these kids have hydrocephalus we're not appreciating, and is that adding insult to injury? If you take that away, the likelihood of a neurological death, at least in our series, has been 0, and God forbid we've not had anybody go to heaven. But nonetheless, a kid that has a big CSF collection, or an adult for that matter, and some of you may know what I'm talking about, it's a disaster. They're in the hospital longer, they're unhappy, they're in pain. So that is a legitimate issue and a problem. And the outcomes, for the most part, 80% of the time the kids are better. 7% they're stable, and roughly 10% of these patients come back at some point for an additional operation because you haven't addressed or resolved the issues that they have. So I'm not going to spend a lot of time in the surgery, just a little bit. I know Dr. Iskandar is going to talk a little bit about this later on. But, when you're looking at surgery, open versus closed, do you open the dura or not? Do you use intraoperative imaging? And I'll talk about that in a second. What do you do with the tonsils? And it's fascinating to talk to the neurosurgeon and say, do you cut them? Do you shrink them? Do you leave them alone? What do you do with them? And that's a debate in itself. What do you do for the dura? Do you use artificial substrate? Do you use the patient's own tissue? And, of course, what about fusions? So for us, the surgical indications, I think this is fairly uniform across the board. Intractable Chiari pain. Intractable meaning their life is being affected, they can't do the things they want to do. And Chiari pain means it's really pain related, strongly related to what you feel is the Chiari. If you operate anything other than that, you're going to end up with a failure. We look for neurological issues. Clearly, when one has compression of the brainstem or cranial nerve findings, that's not a good thing. I think that's pretty inherent, pretty obvious to most of the folks in the audience here. And if we see syringomyelia, and of course you can debate, is that syringomyelia, is an expanded central canal and all that sort of thing. But when we see real syringomyelia, and there's no debate, that makes most of us a bit nervous because that's almost a one-way direction. Once the horse gets out of the barn, you have kids come in with neurological deficits. Some of you will know what I'm talking about. And they don't necessarily get better when you fix the x-ray and so forth. So those are the three things that we deal with. Now, it's a whole nother lecture. I'm not going to bore you with this, and I don't have the time to do this, but there's a lot of debate about opening the dura or not. Dr. Iskandar is wrapping up a study. There's another study that's going on that should address, is it effective to leave the dura closed? Do you need to open it? And like everything else in life, there are probably patients who do very well with the dura not being open, and there are other patients that have to have the dura open to get the success that you're shooting for. So I'm not going to spend a lot of time on that. We do use the ultrasound to try to assess whether we need to open the dura. The reason why you don't want to open the dura is the complication rate explodes when you open the dura. You've got CSF leaks, you could have strokes, you can have all kinds of things that you don't want to have. So if you don't have to open the dura, it's going to be a lot better. So we use the ultrasound in the OR, and this is not an uncommon issue. I know folks have used the MRI, adds a lot of time to it, but the ultrasound will show us whether those tonsils are getting better when we do the bone work and some of the outer layer of the dura work. And the subjectiveness of this is obviously a challenge. It's hard to look at flow rates on I would say cheap ultrasound machine in the OR, but they're about $300,000. But it's not easy, and Dr. Mchinsky's laughing at me because I'm sure she knows exactly what I'm talking about. You really need very sophisticated equipment. But we do look for a number of parameters that would say, wow, this looks a lot better. The tonsils look normal. They're not being wedge-shaped. And if we see that, we'll say, great, we're done. Now, kids that have big holochord syrinxes, we feel a little bit different about that. We're probably more aggressive, and very often those kids don't look any better when you just do the dura, and you very often are put into a position where you do have to open that. But you can see here on this picture here, here's your tonsils, here's the spinal cord, and this is just after opening the bone, doing the outer leaf of the dura. Clearly different. We have not opened the dura, and we're done, and that works most of the time. And we've actually looked at, and again, for the sake of time, I can't go into it, but for our patients that have syringomyelia, something you can measure, there's not a huge difference between opening the dura and not opening the dura, as long as it's not a large holochord syrinx, and that's a whole other talk for another time. So for surgical approaches, you've got the bone only, you've got the bone and the dura and opening the dura, and you can take off the outer leaf of the dura, you can take the dura out and leave that arachnoid, that's this saran wrap clear covering that is supposedly watertight. And then, of course, you can just do everything and take it all out and then put a piece of artificial or the patient's own material back on. You've got the tonsils. Do you shrink them? I used to shrink the tonsils. It certainly makes the x-rays look great. It was some sort of a satisfaction of having the Wicked Witch of the West kind of melt away and, look much better. I don't do the tonsils anymore if I don't have to. You pay for that. The kids throw up a lot. They're not happy. So what's the right answer? I don't know what the right answer is, but I think the less you have to do, it's not a huge surprise that the better off the patients do. And do you stent them? Do you get the CSF to work around that congested choke point where you're having issues? You can't always, with an operation, at least I can't, maybe some of the other surgeons here can, you can't always open that up to make that normal and make it look like it was perfect. Very often there's adhesions and scar tissue in there. There's a lot of very high-priced real estate in there. Sometimes you end up putting a little tiny tube and getting the fluid out through the tube, and that does work wonders as far as syrinxes and so forth. And you got the fusion and so forth. So I'm not going to go into this because time is precious, and I know Benny's going to talk about some of these issues. It's interesting when you look at the literature. There's a lot out there about bone only or bone plus everything else. And the numbers are all over the place as far as success, and I think we've seen the same thing. But the bottom line is, can you figure out who only needs the simple operation versus who needs the full blue plate special and so forth? Just a few words about fusion, and I see a number of folks in here with collars and whatnot. In the pediatric world, we really do everything we can to avoid fusing the patient. Not saying it's right or wrong, I'm just saying in a kid with a developing spine and the inherent limitations that you place when you do a fusion, we really, unless there's some gross instability or there's basal invagination, which is a whole different ballgame, we stay away from fusion if we can. So when we looked at all of our patients, a third of them had just the bone, and it worked well for these patients. 2/3 had the bone and the dura. And actually, when we look at all the kids and some of these were redos, about 14% of our patients had a fourth ventricular stent, which is here, and you'll see more of that in a second. So we'll start off, and we'll do an ultrasound at the outset, trying to get an idea how tight it looks, what's going on real time. We'll remove the arch of C1, which is what you see, if I can get this to work. This is the bone here. We'll do another ultrasound. I wish we could charge for that. It would be great because we do about 1 million of them in the operating room, but we can't. And if we did charge, we wouldn't get paid for it anyway. But we'll do this, and thanks, Paulo. Sorry. So we take off the arch. We then check, is it any different? It usually isn't. We then take off the bone, and people debate how much bone do you take off. And I had a 9-year-old one time say, well, if you take off the bone, will my brain fall out of my head? It's a great question, especially from a 9-year-old. And so we try to limit this and really reduce that choke point. Hal Rickate spends a lot of time saying you need to reestablish the cisterna magna. There's a fair amount of truth in that. And then we do more ultrasounds, and if we start to see that things are looking better, great. It's never that simple. And then we start taking off the outer covering. The dura is two pieces of tissue together. You can remove that outer layer. You can almost see through the inner layer, but you've relaxed it and things have a tendency to bulge out. And that's very often effective, a third of the time. And then you're looking good. You haven't opened the dura. You haven't had a stroke or had hemorrhage or anything else, and we'll stop there, and that often works. And if you can see here, here's the tonsils. They are very gliotic. This is not from what we've done. This is because they've been sitting there in a very tight space being pounded from the heartbeat, and they get beaten up over time. And then when you're done, you put hopefully a watertight graft in. And this is a stent. It's a little tiny piece of tube. It's about the size of a piece of spaghetti from a diameter standpoint. It's going into the fourth ventricle. Spinal fluid's made in the fourth ventricle. Spinal fluid ends up in the fourth ventricle. If it can't get out because there are adhesions, scarring, or whatever, there's an issue, and it gets pushed down the center of the spinal cord more often than not. So if we can find a way to avoid that, sometimes you just open it up and it's clean and you're done. Sometimes it's all scarred in. You just have to put a way of getting that fluid out of there. So to wrap up, just let me share with you a clinical example. This is a young man, 12 years old, who comes in because of scoliosis. They get the MRI, and lo and behold, he's got a large syrinx. Type 1 malformation, 16 millimeters of tonsil herniation, and decent CSF flow. And again, we don't have a way of quantitating that, or we're working on that, so it was hard for us. Maybe we need Dr. Nemchinsky up in Washington, or down in Washington. That's all right, Dr. Vez, we won't steal it from you. But you can see here, obviously, here's his MRI. I think to most folks in this room, they can recognize that he has a very impressive syrinx. And so this is a family that really did not want to take any unnecessary risk. We told them the odds were that he was most likely going to need a bigger operation, but if they were willing, and if the patient was willing to have just the bone only, and we would do the ultrasound, we were willing to go through that if they understood they might come back at a later date if it didn't work. And many families say, I'm okay with that, and the kids are okay with that. So we did a bone only. The ultrasound actually looked better. I was kind of surprised, optimistic perhaps, and that's always a bias there. And we said, all right, he looks pretty good. The ultrasound looks good. Call it a day. Keep it simple. Unfortunately, as you can see, 11 months post-op. This is 20 months and 20. The syrinx hasn't gotten any smaller. In fact, maybe it's even a bit bigger. Now his skull is getting a little bit worse. He's still asymptomatic, but folks are getting more concerned, appropriately so. And we finally decided, look, this is what we've talked about. We need to go ahead and do the big operation, open the dura, explore the fourth ventricle, and all that sort of thing. So we did, and to no surprise, the outflow, the obstruction of the fourth ventricle was very significant. I'll show you some slides in a second. And when you look at this, a lot of scarring in here. And this is outside the dura. We haven't opened the dura. But even after a year, 2.5 years, he's still scarred in a bit. And you always wonder about that. But when you actually get down to the dura, you can see there's just all sorts. This is normally clear. It's like, looking through a window. It's nice and clear. But what happens is with all the scarring and trauma, it becomes opacified. And it's clearly an indication of tethering, whether it's in the spinal cord or up in the brainstem. And there's no question he was socked in. And so here's the tonsils. As we start in part, here's the outflow of the fourth ventricle. It's normally a big, nice, open road, highway. You can get fluid out of there and it drains out, goes down the spinal cord and up and around. Socked in scar. Pica, these are the blood vessels that are very, very critical to the brainstem. They weren't moving very easily, so we said, look, let's just put a stent in. And here he is after the fact. He's about not a little bit smaller, 6 months later, but clearly in the right direction. And you can see 18 months later, the syrinx is a lot smaller and will probably continue to get smaller. And this scoliosis is getting better. He did not need surgery for that. In fact, he's even out of his brace now. And that's not an uncommon story. So to conclude, I don't want to push the time here. So no question the clinical presentation in kids is extremely variable. And it may reflect an ongoing continuum. And it's certainly watching these kids as they evolve over time. Most folks, when they start having issues, have surgery, but some don't, and some refuse, and you can watch them as well. A lot of midline abnormalities, a lot of comorbidities. I suspect there's more going on here genetically than we appreciate. That should clarify itself, hopefully, in the next couple of years with some of these huge projects that are coming to fruition. No question, Syringomyelia, no stranger to anybody in this room, is a common presentation. May very well be the most vexing and challenging part of Chiari malformations, and they can develop over time. I mean, we've been doing enough pictures now and tracking people long enough to see they do evolve, they do get worse, and so forth. Unfortunately, you don't always get the function back when you deal with it. And the etiology still is very unclear, despite all the great work that's been done by a number of folks. Is it too small a space? Is it the fluid can't get out? Is it something else? Is it something in between? No question, we're seeing a lot of incidental Chiaris nowadays. It's not uncommon. As I said, more than 50 kids a year in our institution. It's not a benign problem. Doesn't mean everybody needs surgery. As I demonstrated with the prospective numbers, 7% went on to require surgery, but it is an issue. And then, of course, what's the deal 10, 20, 30 years later? It may be a higher number. We just don't know. A lot of predisposing factors that we've been able to at least look at in these patients in family history, exertional headaches. The 1.5s have a higher likelihood when they come in incidentally to go on, and that may just be a reflection that there's more downward herniation than we're appreciating. And obviously lots of surgical approaches, and a lot of folks have spent a lot of time, Benny and others have spent time trying to figure out what's the right answer. The right answer is you do as little as you have to get the most bang for the buck, the best results of that. And the role of minimization in neurosurgery has been going on since Walter Dandy in the 1920s. This isn't new for us as neurosurgeons, but it's an ongoing problem, whether it's a brain tumor or Chiari malformation. Complication rate is real. And if you're honest about this, and I think anybody that has to come back in the hospital and spend 4 days to deal with a big CSF fullness in the back of their neck, and they're unhappy and in pain, and you're worrying, you're waiting for your CSF cultures, that's a complication. That is not what we expect to happen. That's very real. But for the most part, done well and done in place to do a lot of this, your significant complications, strokes, neurological deficits, or worse, should be low single digits, if not close to zero. The majority of our patients do get better. I think this depended upon how aggressive, how careful you are, and how aggressive you are really operating on the right patients. Just because somebody comes in with 6 millimeters tonsillar herniation and the neck is killing them, they're having headaches, and then you find out that they have EDS and they can take the thumb and touch the forearm, or they're dislocating their shoulders all the time, you're not going to help them with a Chiari decompression. You will probably make it worse. And then unfortunately there are patients that do come back. It's about 10%, even when you have a pretty good idea of what you're doing. And we often see with the failures that do come back, these are the kids that end up having some type of obstruction of CSF flow. And I've yet to figure out how to tell if that's obstructed or not, and I'm hoping with better MRIs, maybe 7 Tesla magnets, maybe a 3 Tesla magnet with the right type of software will tell us if there's an obstruction. Now we're trying to figure out who's obstructed and who's just got a tight space. We certainly need to look and get a better idea. You saw earlier very nicely, not a lot of work being done on CSF flow and coming up with clinical correlation and coming up with real numbers. I think that'll take off as time goes on with the work that's being done by people in this room. It would be great to, and you'll see more about this, is the anatomical volume an issue or not, and how do you address that? And is that part of the Chiari? It's always very beneficial and critical to look at your failures. Why did they fail? What could you learn from that? Part of that also would be looking at animal models, and we're actually embarking on a grant to do this with the King Charles Cavalier Spaniels. Can the animal models help us figuring this out? And I think, again, having a simple way of looking at volumes, within 5 seconds of looking at versus taking an hour to figure out what the volume is, will give us another way of objectively looking at what we're doing and so forth. So I'm going to end there. Hopefully I haven't gone over too much, but obviously I'm happy to answer any questions during the panel session. Thank you.